So my topic is more basic, and what I will try to do is focus more on the causes, like Dr. Kakrani told you, of anemia in diabetes, but the major component will be the renal, how much the renal disease contributes to anemia. So my interest in diabetes and anemia stems from two of our publications. One was in the Indian Journal of Endocrinology and Metabolism, and the other was a position statement in JAPI. This was followed by a South Asian statement, which was subsequently published in Diabetes and Metabolic Syndromes. So what I will be presenting to you is from these three publications. This is the road map that I'll be taking, which I told you when I just started my presentation. So why am I talking about anemia? Because patients with diabetes 2 times more likely to have associated anemia, with a greater risk of progression of the micro and macrovascular complications, including non-healing diabetic foot ulcers, along with a tremendously increased morbidity, mortality, more because of cardiac dysfunction, CHF. Both type 1 and type 2, whether it's men or women with diabetes, have a greater prevalence of anemia. In this study, it was shown that 1/3 had a normocytic normochromic type of anemia, along with microvascular complications. I'm not trying to show you the fundus here, but I'm trying to highlight here that if there is associated anemia, there's a 2 times greater risk of developing diabetic retinopathy, a 5 times greater risk of proliferative diabetic retinopathy. Not only that, it is an independent risk factor for diabetic peripheral neuropathy, as well as cardiovascular autonomic neuropathy. So what does it show you as far as the renal disease is concerned? Anemia develops early in CKD. There are 2 to 4 times greater chances of coronary artery disease, cerebrovascular disease as well, the greater risk of stroke. Anemia also predicts increase in the left ventricular mass, dilatation, CHF, and death. So the punchline here is that anemia can wreak havoc in the life of a diabetic. We are aware of the definition of anemia. We are following the ICMR criteria. And remember, in diabetes, the magic number is 7. When we talk of control, for severe anemia, again, the same magic number if it's less than 7. So these are the multifaceted causes of anemia, which I will be addressing as I go along. As far as nephropathy is concerned, neuropathy, hyperglycemia, as well as RBC abnormalities, they affect the EPO, that is erythropoietin, as well as the RBC survival. So coming to some of the diseases which I will try to address amongst the multifaceted causes, this is an important but a rare entity which you should be aware of. If your patient has a megaloblastic anemia, this should be considered. The patient will also have associated deafness. It starts from infancy or early childhood, and especially if patients give you a history of consanguinity. As far as nutritional deficiencies are concerned, B6, B12, folate deficiency have also been documented in patients with diabetes. Prevalence of iron deficiency is rampant across South Asia as well as in India. Tuberculosis, yes, that should also be considered because we are seeing there's a resurgence of tuberculosis with diabetes, and it is an easily correctable disorder. What about metformin? Yes, the longer the patient takes metformin, the chances of vitamin B12 deficiency arise. And in one of the talks earlier, it was highlighted that in vegetarian Indians, this is a likely possibility. So as you age, as you take more of metformin, so the dose as well as duration. and the deficiency may start as early as 4 months. There are several other causes which I will not go into details. What about thiazolidinediones? They cause a 2 to 3% reduction in hemoglobin. And you know, the earlier speaker was emphasizing the use of pioglitazone with NASH. This is because of hemodilution, which occurs because of increase in the plasma volume. ACE inhibitors and ARBs should also be kept in mind. If your patient is taking losartan, then there may be a reduction of hemoglobin by 1 gram. And 1 gram is very significant in a patient who has diabetic kidney disease. So these are the mechanisms by which ACE inhibitors and ARBs lower the hemoglobin. They not only suppress the IGF-1, they cause degradation of physiological inhibitors of hematopoiesis, and they cause direct blockade of the pro-erythropoietic cells of angiotensin II on red cell precursors. Diabetic autoimmune neuropathy, I've already shown you a study which can affect the EPO levels, leading to ineffective erythropoiesis. Heart failure. Diabetics per se, there is a risk of increased heart failure, which can also affect kidney dysfunction. And a lot of these patients have associated nutritional deficiencies. As far as diabetic foot ulcers are concerned, there will be delayed healing because of reduction in the availability of oxygen. Even in type 1, you have more of pernicious anemia because it is an autoimmune disorder, and iron deficiency anemia is frequently associated with autoimmune gastritis. Now, I'll be focusing the rest of my talk more on diabetic nephropathy, talking about anemia in CKD, and subsequently a little bit about the management. So in CKD, it's very common. As the CKD advances, you can see in stage 3, it's only 5.2%. In stage 4 is almost 45%, and in stage 5, it is universal. So it is a leading. Why diabetic nephropathy? Because we know it is the leading cause. Excessive CV morbidity and mortality is associated, affects the disease outcome, and you have to be very balanced here. It's like that A1C of 7. Here you cannot overtreat, and you should avoid undertreatment. Both. The balance here is extremely important. But remember that even in diabetes, not all kidney disease is attributable to diabetic nephropathy. So this is very clear that the prevalence of anemia in CKD, whether it's men or women, increases not only as the age advances, but as the stage of DKD increases. This is not only correlated with the GFR, but with the micro or macroalbuminuria as well. Along with the GFR, we look at the saturation levels, transferrin saturation levels. So in type 2 diabetes, this is a relative summary slide. These are the factors. We have decreased erythropoiesis because of several reasons, all leading to anemia, which is a high output state. We can have heart failure, cardiomyopathy, myocyte death, and progression of renal disease as well. What about nephrotic syndrome? There is increased iron excretion. We have reduction in iron as well as erythropoietin. Transferrin catabolism is increased. There is reduction in the erythropoietin production, secretion, as well as hyporesponsiveness. So all this leads to, this is all interrelated, CKD, anemia, CVD, as well as diabetes. This is a reciprocal relationship. And if you look at patients who have both diabetes with anemia, the severity of renal impairment, it correlates accordingly. I referred earlier to a fall in just 1 gram per deciliter fall in hemoglobin. So these are all the abnormalities which can result, whether it's LVH dilatation, whether it's a systolic dysfunction, chronic CHF, or ischemic heart disease, with just 1 gram fall in hemoglobin. So now what you should be aware of, because I said we are walking the tight rope here, what are the target levels and why? How should clinicians achieve them? What is the difference between correcting anemia and maintaining it? Are those erythropoietin stimulating agents different? And what benefits do we aim for in our patients? A little bit about erythropoiesis. We know that the RBCs develop in the bone marrow. Erythropoietin is a hormone. 90% is secreted from the proximal renal tubules, and it stimulates the stem cells to increase the RBC production. Whereas iron is essential in the latter phase. 2/3 of iron in the body is in hemoglobin. So this is how I have depicted it pictorially to make it clear. The initial part is erythropoietin dependent, and the latter part is iron dependent. The role of the kidney, in patients with CKD, the kidneys are unable to produce sufficient erythropoietin to stimulate adequate erythropoiesis. So what are the essential ingredients? Those of us who have grown up reading comics, we know about Popeye, who used to have a good diet of spinach. A little word about hepcidin. If we have increased levels of inflammatory cytokines, they enhance the production and secretion of hepcidin. So what is hepcidin? It is a protein that inhibits the intestinal iron absorption, and it impairs the transport from the reticuloendothelial system to the bone marrow. So this is the site of action of hepcidin. Increased hepcidin in iron sufficiency and inflammation, decreased hepcidin, erythropoiesis, iron deficiency, as well as hypoxia. So what are the clinical practice guidelines? You've done a clinical exam, you've gathered your indices, the retic count, and you've done your serum biochemistry, apart from looking at the fecal occult blood testing. These are the comparison of findings which you should be aware of. What are the levels of iron, ferritin, transferrin saturation, total iron binding capacity, and the log ferritin, as well as the peripheral blood smear, whether it's iron deficiency anemia, anemia of chronic disease, combined hereditary hemochromatosis when there's an iron overload, thalassemia, as well as metabolic iron overload syndrome. In CKD, we will not only talk of iron replacement, folic acid, pyridoxine, prevention of blood loss, erythropoietin replacement, correction of the uremic environment, and blood transfusion. These are all which will be required. There, I've given you the list of preparations for the management of anemia. I'll split them up into oral and parenteral. So these are some of the parenteral forms of iron, whether it's iron dextran, iron sucrose, or sodium ferric gluconate. There are subtle differences in the nature, molecular weight, iron transfer, the half-life, renal excretion amongst all the three. As far as different oral iron preparations are concerned, again, I've listed them. The absorptions vary, the timing from meals is similar for all, and the side effects are basically uniform for all of them. As far as erythropoietin stimulating agents are concerned, they have totally revolutionized the treatment of anemia. The non-hematopoietic actions are cardioprotection, anti-inflammatory properties, neuroprotection, angiogenesis, as well as renoprotection. The fundamental thing to remember is that before we use them, we have to correct the iron deficiency. And several are available, short-acting, long-acting, once a week, even fortnightly, once a month as well. If you look at the comparison between the two treatment regimens, whether it's darbepoetin alpha or epoetin, the response after 1 year is 100% with darbepoetin alpha as compared to epoetin alpha. The side effects, yes, there are hypertension, patients may have seizures, flu-like symptoms, headache, diabetic retinopathy, red eye, and PRCA are also there. What are the optimal hemoglobin levels that we should try to achieve? We should typically maintain the hemoglobin levels in adults, young people, and children over 2 years of age between 10 to 12 grams. In children less than 2 years, we should target between 9.5 and 11.5. And like I've said, do not wait till your aspirational, that is less than the aspirational range. Take action when even 0.5 gram difference is seen. So overall, you weigh the risks and the benefits and then decide as to how the treatment modality is to proceed. This is an algorithm. So you looked at your patient. We've looked at the target hemoglobin is less than 12 gram in a non-pregnant woman, less than 11 gram in a pregnant woman, 13 gram in men. So we've done a clinical evaluation, reviewed the CBC, looked at the MCV, and then we've done the serum indices. So of course, whatever deficiency is there, if it's vitamin B12 or folate deficiency, treat accordingly. Similarly, for iron deficiency, if there's coexisting iron deficiency with anemia due to chronic disease, then we have to look at the TIR log scale. If the serum ferritin is more than 100 and the saturation is more than or equal to 20, then we think of anemia of chronic disease. Then we evaluate the underlying cause, whether it's malabsorption, celiac disease, inadequate iron intake, or look at inflammatory disease, CKD with or without diabetes. And the management will be according to the deficiency, or we will start an erythropoietin stimulating agent. If the hemoglobin is less than 10 gram in a dialysis patient or less than 11 gram in a non-dialyzed patient. And the goal here, I have already told you, is 11 to 12 gram per deciliter. Monitor every week until stable, and thereafter every month. So the take-home message, I've tried to highlight, it's widely prevalent, early in onset and progressive. The two most common causes are iron and erythropoietin deficiency, the associated morbidity and mortality. The mainstay of treatment are those two agents. As far as erythropoietin stimulating agents are concerned, they vary in duration of action and frequency of administration. You should be aware of the target hemoglobin, and darbepoetin is a long-acting erythropoietin stimulating agent with certain advantages. Thank you very much.